My name is Rebecca Robinson, and this is my final presentation for Nursing 5811 at the University of Connecticut, and it is on SATB2 associated syndrome. I chose this topic in honor of a close friend of mine whose daughter was diagnosed with SAS, SATB2 associated syndrome at a very young age, before she was 2. She was noted to be born with a cleft palate and had severe dental anomalies as her teeth began to erupt. She also exhibited autistic-like behaviors with delayed cognition and truly never gained the ability to speak despite aggressive speech therapy. She had birth to 3 come in, she did speech therapy, she did occupational therapy, and still never was able to speak. At the age of 5, though, she is fluent in sign language and full of smiles. So here's a little bit of background on SATB2 associated syndrome, also known as SAS. It is caused by an alteration of the SATB2 gene. This gene is located in chromosome 2 at position Q33.1, which produces the protein SATB2. SATB2 is also known as DNA binding protein. This protein in humans is encoded by the SATB2 gene. Specifically, it binds nuclear matrix attachment regions and is involved in transcriptional regulation and chromatin remodeling. The SATB2 shows a restricted mode of expression and is expressed in certain cell nuclei. This protein is mainly expressed in the epithelial cells of the colon and rectum and the nuclei of neurons in the brain. Its prevalence and epidemiology. So unfortunately, it is unknown how rare or how common SAS may be. There are studies that have shown that screening for the mutation of the SATB2 gene in babies with isolated cleft palates have failed to identify actual diagnoses of the SATB2 disorder. SAS is probably not a common cause of the cleft palate, and other signs and symptoms are needed to determine who may have SAS. So in other words, there was some thought that any child that was born with an isolated cleft palate was positive for this mutation of the SATB2 gene. There have been at least 40 patients with SAS that have been well described in medical literature. The number is higher of all the cases that have deletions in the chromosome 2 around the SATB2 gene, and they are also included. The average worldwide prevalence of SAS is 1 of 800 live births, and is usually diagnosed before the age of 2. And this is because one of the biggest symptoms and signs of SAS is speech or lack thereof. So as children are getting, they're developing their language and formulating language at a normal rate, these children are slowed, and delayed, and most of them are absent with speech. These phenotypes are not seen in all patients, and they do not always lead to a concrete diagnosis of SAS. So just because there's a child that has speech anomalies, abnormalities of the palate, teeth anomalies, behavioral issues, and all of this starts before the age of 2, it doesn't automatically lead to a diagnosis of SAS. And the reverse is true. all of those that may be diagnosed with SAS don't always have all of these classic phenotypes. Clinical presentations of SAS. So there's significant neurodevelopmental disorders in the affected individuals. And here are some examples of what may be included. Hypotonia as an infant and feeding difficulties, and usually just a global developmental delay. Severe speech delay, the apraxia, but more commonly is truly the absence of speech. Gross and fine motor skill delays and cognitive delays. Behavioral issues. My friend's daughter was noted to have autistic-like behaviors at a young age, and that also led them to seek medical guidance. So they have hyperactivity, they have trouble sleeping, there's sometimes aggression and frustration, and a lot of that is due because of the inability for them to communicate. The palate anomalies, so cleft palate, bifid uvula, and high arched palate, and dental anomalies as well. So despite the underlying genetic mechanism that results in the alteration of the SATB2 gene, there have been some clinical features that have pretty much always been described. And the developmental delay is almost always universally reported and frequently in the severe range. Language development is also a huge area of developmental delay and is affected in the majority of patients. Behavioral abnormalities as well, and facial dysmorphism, and that's usually due to the anomalies of the palate and the teeth, so it causes this dysmorphism of the face. In order to diagnose SATB2, it's been established in a proband by the detection of one of the following: heterozygous intragenic SATB2 pathogenic variant, heterozygous non-recurrent deletion at the 2q33.1 position, intragenic deletion or duplication of the SATB2 detectable chromosomal microarray analysis, or CMA, chromosomal translocation with a 2q33.1 breakpoint that disrupts the SATB2 gene, and molecular genetic testing approaches can be included in a combination of the CMAs, a multi-gene panel, or a comprehensive genome sequencing, as well as an exome array. So despite all of these genetic tests that can be done, there's been no specific criteria outlined to make the diagnosis of SAS. It should be considered in anybody that has developmental delay with severely compromised or absent speech, and that also has palatal and dental abnormalities. So those are really the two things. If there's a child, less than 2 years old or around that age that has a speech delay and has any kind of palatal abnormalities, they really should be ruled out or ruled in for SAS. So regardless of the medical history and the findings on the physical exam, any of the potential mechanisms that result in the alteration of the SATB2 gene needs to be documented through genetic testing in order to make the diagnosis of SAS. The testing that could show changes in the SATB2 gene include the following. There's a chromosomal microarray test, and this looks for deletions or duplications throughout all the chromosomes. This test is widely available in the US and around the world. It's considered to be the first line test in the evaluation of developmental delay or birth defects. The majority of the deletions or duplications in chromosome 2 that include the SATB2 gene should be able to be detected by this test. The sequencing of SATB2. So this sequencing of a gene refers to looking at all the individual letters in the gene for misspellings. The sequencing of only the SATB2 gene has very limited availability at only a very few labs in the world. According to the Genetic Testing Registry, only 3. This test, however, is unlikely to be commonly ordered since it's not cost effective to look at just one specific gene as opposed to all of them. Next generation sequencing testing. All the individual letters and several genes are looked at simultaneously. Because developmental delay and severe speech delay are main features of the SAS, testing for misspellings of the SATB2 gene is often conducted by this type of test when no other more distinctive medical issues are present. So if there's isolated palatial issues and speech development, this test would be effective. This is included in panels that are offered by several laboratories that target autism and developmental delays or intellectual disabilities. Clinical exome, whole exome sequencing. The coding regions of several thousands or all of our 20,000 genes are looked at simultaneously. It's becoming really popular worldwide. The genetic mechanisms and abnormalities. It's a heterozygous inheritance pattern. Only one copy of SATB2 has a given change, and the other copy is, quote, normal. It's a de novo disorder, which means that neither parent has the same gene change. Therefore, it is not inherited. SAS is caused by alterations of the SATB2 gene. And again, this gene is located in chromosome 2 at position Q33.1, and it produces a protein called SATB2. This, again, specifically binds to nuclear matrix attachment regions and is involved in transcriptional regulation and chromatin remodeling. So how do we manage patients with SATB2? Well, the big thing is genetic counseling, and you need symptom-based support. So neurological issues, you need to consider a brain MRI or an EEG at baseline, treat seizures if they're present, neurosurgery referral if needed, physical therapy evaluation, physical therapy and occupational, they could work hand in hand, speech therapy, orthotics if there's issues with walking. Any craniofacial abnormalities, they should see a specialist for the cleft palate, dentistry, and GI issues. A lot of times if they have cleft palates and issues with their teeth, there's issues in feeding. So you may need to get a gastrointestinal consult to make sure that their nutrition is up to par, and maybe they need special nipples or bottles for the cleft palate and feeding education. Social, financial, and ethical considerations. So it is important to educate. The deletions, the duplications, or mutations of the SATB2 gene are de novo. So it is new to the child and not passed on from the parents. It is not inherited. So there aren't related to other risk factors during pregnancy. A lot of times parents feel this overwhelming guilt that they passed on a mutation to their offspring, or something that they did during pregnancy affected that. It is important for the parents to understand that this is de novo. But by the time the mother knows that she's pregnant, the SATB2 changes are already present and have already begun affecting development. The recurrence for families having another child with SAS assuming neither parent has the same change in the gene, are very, very, very low, like less than 1%, although it will never be 0. The social stigmas can result from craniofacial abnormalities and dental defects, intellectual delays, limited or absent speech, and behavioral difficulties. And prenatal testing has not proven to be beneficial due to the de novo mutation. And that concludes my presentation on SATB2. Thank you.